Healthcare careers shouldn't be a mystery, and they shouldn't be reserved for people who already have connections or know the right people. My name is Tanvi, and this is Healthcare Unveiled, where we have honest conversations with healthcare professionals about their real journeys, the good and the challenging parts, so that you can figure out if and how this path might work for you. Today we have Dr. Ruben here. Nice to meet you.
Thank you. Nice to be here.
Just to begin, could you introduce yourself and what you do?
Yes, absolutely. My name is Shivani Ruben. I am an internal medicine physician. I practice primary care, predominantly geriatrics as far as my patient panel, and I work in a clinic setting in Sacramento, California.
Awesome. What initially drew you to medicine, and when did you become interested in integrative medicine specifically?
So I knew from a very young age that I wanted to go into medicine. And I realized pretty quickly that medicine is a career that once you choose that route, you're pretty committed right from the beginning.
Yeah.
So I was pre-med in undergrad. I went to UC Berkeley for undergrad, and the pre-med track was incredibly rigorous. And it was a huge commitment. And so from the beginning, I knew that this is the path that I wanted to be on, and this is what I was motivated and dedicated to do. And then as far as becoming an internal medicine doctor, I didn't really know what type of doctor I wanted to be. I just knew that I definitely wanted to take care of patients longevity wise. I wanted to take care of people and their families and get to know them over many years, as opposed to working in the hospital when they're at their sickest. And then I maybe wouldn't be able to see them again after that, hopefully. I knew that I wanted to sort of incorporate our lives together, if you will. And so I wasn't sure if I wanted to do family medicine or internal medicine. And then I didn't know if I wanted to do a fellowship. And so thankfully, after that initial commitment, the world is your oyster as far as, what type of doctor you can be. So for me, taking care of adults and predominantly elderly adults in a clinic setting is now what I do and what I love.
Can you explain what integrative medicine actually is for listeners who may not be familiar with it?
Yeah, so internal medicine is 18 and over, so it's adults only. And during residency, so everybody goes to the same number of years of medical school, but residency is a different number of years depending on what you're planning on specializing in. So there's family medicine, internal medicine, OBGYN, surgery. And so for internal medicine, your patient population is only 18 and over. And during those 3 years of residency, we focus on all the internal organs of the body. So we do rotations in cardiology for the heart, nephrology for the kidneys, pulmonology for the lungs. And so we really focus those 3 years on the workings of all the internal organs of the body. And internal medicine is one of the residencies where people can then specialize into the different specialties like cardiology and nephrology and pulmonary.
And since we're kind of talking about patients, was there a specific patient case or a moment that made you realize that integrative medicine was the right approach or right path for you?
I want to say a case or a patient that I continue to sort of think back on now. It was when I was in residency. So residency clinic is typically, well, my residency clinic was a very underserved, low socioeconomic population of patients who came in, they saw the residents, and every 3 years the residents are turning over. And so they were people that didn't necessarily have the best chance of healthy living as maybe some of the private patients. And so I remember I had a patient who lived near the clinic, so lived nearby. He walked to all of his appointments. He was very compliant, who took care of himself. He did what he needed to do. And he had diabetes, but his diabetes was really well controlled. He always checked his sugars. He took his medications on time. Well, one of the things that can happen with diabetes can cause multiple complications. And so one of the complications that can just happen is diabetes can affect our eyes. It can affect the retina, and it can cause something called retinopathy, which is the sugar damages the blood vessels in the eyes. And people with diabetes, even if it's really well controlled diabetes, can eventually lose sight of their vision. And so this patient, even though he took care of himself, he didn't ever get the screening for diabetic retinopathy. There's a screening test which eye doctors can do to see is there any signs of damage, and there's treatment that they can do. He never got that screening. And, no pun intended, but hindsight being 2020, I know that I wrote in all of my notes that he was supposed to do this, right? It was something that I mentioned, but I never really asked about how was he going to get this done. There was no eye doctor within walking distance of this patient's home, whereas he came to all of my appointments and walked to them. So eventually what ended up happening is he did lose vision. And because he lost his eyesight, he was unable to dose his insulin properly because they were in the small vials with the needles and he had to draw up the insulin. So he's unable to dose his insulin properly. Because he was unable to dose his insulin properly, his diabetes got worse. It became more and more uncontrolled. Because his diabetes became more uncontrolled, he ended up developing a infection of his leg, and the surgeons had to amputate his leg. And cut it off to, sort of control the infection. And things really just spiraled, and it really affected obviously his quality of life because here was this man that walked to all of his appointments. He walked everywhere. He did everything. He was very independent, to not having access to this one test, which we know is necessary. I know it was written in my notes, but there was nothing that was done to really help ensure that he gets that done, and what an impact it had on his quality of life. I sort of always think about, it's what I do from a primary care standpoint is so all encompassing. I can't just think about the number on the lab. I can't just think about whether his sugars are well controlled or not. I have to think about all the ways that he needs to be able to have access to care. And so that would be a case that I definitely think back on often.
Interesting. So continuing on with this theme of access kind of, how do you have the conversation with the patient when you know that they need a screening or test, but that they may not have access to it? Or have you ever had to decide which screening to prioritize because a patient can't afford to do all the recommended ones?
Yeah, absolutely. Thankfully, I work for an organization where we have a whole slew of services available for patients, including things like social workers and case managers and like Lyft and Uber coupons, where we really are able to help facilitate things for patients. But you hit the nail on the head. Often we just have to prioritize what can be done now, what it can safely be maybe held off. Classic example, after the COVID-19 pandemic, there was a lot of mistrust about vaccines.
Yeah.
And yet the same people who used to get their flu shots regularly on time are now sort of reluctant about this quote unquote government pushed vaccine, the COVID vaccine. And it would be very easy just to be like, forget it. I'm just not going to have this conversation with people. But that's obviously not the right thing to do. It's more just, you used to get the flu shot all the time. It's definitely still important to prioritize that. We did all of the childhood vaccines leading up to becoming an adult, and really just telling people the data behind it, the risks, acknowledging what risks there are. People felt sick after getting COVID vaccines, and to acknowledge that that is a real thing that people can feel. And it's called an immune response. Anytime we have any vaccine, we can feel a little punky for a couple of days. That's a good sign that my immune system is learning what to do. Also acknowledging that no, vaccines don't prevent us, especially the COVID vaccine or the flu shot. They don't prevent us from getting the illness. It prevents us from dying of the illness, And so acknowledging that, people will say, I don't want to get the COVID vaccine because I've had it before and I still ended up with COVID. Well, yeah, but you live to tell about it. That's the whole point, is that you'll survive this illness. And so really and truly just meeting people where they are, and respecting their opinion, acknowledging their opinion, and then always backing what we do with science. That is what separates medicine and the integrity behind medicine with so much else in this world. Is this isn't my opinion. This is science.
Yeah. So you probably meet a lot of different types of patients within your field. How many patients do you typically see in a day, and what's kind of the mix between routine checkups or problems or chronic disease management within your
Yeah,
patient?
that's a really good question. And the answer is, thankfully, for the group that I work in, it's whatever you want it to be. So we have different visit types. So they are whatever you want your schedule to look like. So in an hour, I can say that I only want to see 2 patients per hour, or I want to see 3 patients per hour. Most primary care doctors in their right mind do not see more than 3 patients an hour, because you really want to make sure you spend enough time with them, right? So I'm either seeing a patient every 20 minutes or I'm seeing a patient every 30 minutes. My personal schedule is every 20 minutes, but all of my partner's schedule is every 30 minutes per patient. And so then it's A new patient appointment, maybe I want to spend more time with the new patient because I'm getting to know things about them for the first time. We're talking about their parents' history and, their socioeconomic situation at home. So new patients, maybe I want to make that an X appointment. So a 20-minute visit times two. So that would be a 40-minute visit. So all of my new patients are double the amount of time. And then there's other types of visits, which definitely we want to make sure we spend more time with the patient. So typically physicals, if I see somebody once a year, I want to talk about all the preventative health screening, their mammogram, their colonoscopy, fasting blood work, all their vaccines, everything that their pap smear, everything that they needed done to prevent illness from happening. Medicare, so different insurance types have different types of preventative visits. Medicare has something called a wellness visit. So either your physical, your wellness visit. And then another type of visit is called a hospital follow-up, where the patient was just admitted. Maybe things were changed as far as their medications. Maybe they need referrals. It's a very scary time in their lives. So those three types, the preventative visit for physicals, preventative visit for wellness, and the hospital follow-ups, all of those are also X visits. So instead of 20 minutes, those will be 40 minutes. And so my day varies. Some days I have more patients than others, but they may be less complicated, more just, sort of acute, a couple things bothering them. Other days may have less patients, but they may be more intense and, sort of draining, if you will, time consuming. So the number of patients per day really just varies, but it's up to the doctor as to what they want their day to look like.
So would you say that in comparison with other medical specialties, you have more or a better work-life balance, I guess?
I think so. Well, okay. So I'd be lying if I said yes. No, and I'll tell you why. I hope it's okay that I'm being completely frank. Something changed during the pandemic. And I don't even know if the pandemic is really the catalyst for this change, but there's something different from when I first became a doctor to practicing now. Patients have access to me on their cell phone. They can open up their clinic app and send me a message. And that message could be about something that I have not even ever talked to them about, asking, what do you think of this supplement? And so those messages come to me, and I feel the responsibility and the burden to respond to those messages. And so we do find that a lot of new doctors coming out of residency and going into primary care are kind of really struggling with the number of messages that we get outside of just seeing patients. If it were just seeing patients, that would be work life galore. I mean, that would be ideal. But primary care is not that anymore. And so there are some things that clinics just do and have to implement with their patients, which is if there's an issue that a patient is messaging me about that I have not talked to them about, my staff should know to offer that patient an appointment, because every interaction that I have with my patient deserves a face-to-face. Even if it's a video visit, it deserves a conversation. It deserves this dynamic interaction where they can ask questions and have, real-time feedback. And so it really becomes a slippery slope when we find ourselves just messaging back on these messages that they send me through the app. It is not fulfilling. That's not why I went into medicine. I went into medicine to have these long lasting relationships with my patients, not to text them. So work-life balance, I think it is doable, but not ideal.
So on the topic of long-term relationships with your parents, with your patients, what exactly do you love about having that sort of relationship with your patients? And would you say that that's the most like rewarding aspect of your job?
Absolutely. You know what I love? So most of my patients are elderly and sort of in their grandparent stages. And so the favorite part of my day is when the patients show me pictures of their grandbabies who are now so much bigger and now so much, I'm seeing them 6 months apart and they're so much bigger. And I just love hearing about all the successes and accomplishments of the grandbabies. So it really is getting to know the extended family through pictures and through stories.
Awesome. So how do you deal with kind of going on to the challenges of that you face in your day-to-day? What would you say is the most frustrating part or aspect of primary care?
Where can I start? How much time do we have? I'm just kidding. There's a lot going on right now that we didn't touch on. So, the lack of science right now is very scary, but my patients are open to having the dialogue. And so that's not something that I would say that that's the hardest part. The messages, the people that send the messages don't expect a response. When they are told by my staff that Dr. Ruben would like to, talk about this at an appointment with you, they're actually very appreciative of that. So, to answer your question, what is the most frustrating part of medicine right now is, you think you go into medicine after having learned so much about what medications are good, what medications are cause more harm than good, what treatment options there are that exist, what scan needs to be ordered. Here I am thinking that I know the pathophysiology of this disease, and so here's the test that I need to order or the medicine that I need to order, only to be met with an insurance denial. And so that's something that they don't teach you that in medical school as far as, what information is needed to ensure that you're ordering the inhaler that's on formulary for the insurance company. That's the non-romantic side of medicine, which I didn't know anything about until I started practicing. So it really is just the limitations and the restrictions put upon us by insurance companies.
Oh, interesting. And with today's day and age, with the internet so accessible to everyone and a lot of misinformation also available online, how do you deal with patients that come to you with how do I word this? How do you like deal with patients who come to you with these like preconceived notions about their like treatment or like certain expectations for you?
Yeah, I think you have to embrace it. As a primary care physician in the world of AI that we live in right now, you have to embrace it. I mean, I can't get mad at my patient for Googling their symptoms or for asking ChatGPT, what these are. I just have to instill that I tell my patients, you know your body and I know medicine. And the whole reason why we're having this conversation is not so that you can order what test you want from a menu. It's to be vulnerable and tell me what's bothering you. And then I can talk to you about what's necessary, what's not necessary, what this can be, what this isn't, and reminding my patients that there's a very human side of taking care of people that things like ChatGPT cannot serve. And so it used to be frustrating. In fact, even just today, I had a patient tell me that she wanted me to order a cortisol blood test. And, at first, and this was like my 9 o'clock in the morning on a Monday, the first Monday of the new year. And I'm like, really? So I just kind of sat back and I asked my patient, well, I'm happy to order whatever test you feel that you are interested in. But what are you planning on doing with the cortisol results? If it's high, what's your game plan? If it's low, what's your game plan? And she was like, oh, well, I don't know. And so we sort of talked about the reason why she wanted to order this test, the symptoms that she was having, and how to really just treat her as opposed to just checking a test and ordering blood work on her. And she left the visit feeling better about her game plan, even though her checklist wasn't met, even though she had a list of tests that she wanted ordered. We didn't do that, but she did feel good about being taken care of. And so I could have easily been irritated by that, but it's really important that it's incorporated into how I treat my patients and that I even celebrate it or at least welcome it and just be open to it. But I'm still learning.
Earlier, we were talking about health insurance and how that can kind of hinder your ability to treat a patient. But other than that, or if you want to go deeper into that, that's okay too. What's the biggest systemic issue that you face in primary care when it comes to treating patients?
Yeah, definitely access. So, bigger cities have lots of specialists and really cool tests that can be done. And then there are rural areas where people just don't even have access to primary care. Even the city that I live in, it's a really long wait to establish care with a new doctor or to see a specialist. I mean, it's a big city and there are way more patients than there are doctors. And so access to care, access to timely care, these are things that are really difficult and even more reason for us to embrace technology and AI and video visits so that, even if you can't physically be in the same room with the patient, you still are able to provide some semblance of care, which is better than nothing. Access, I would say, is one of the hardest things that we're dealing with right now.
I've had a lot of other people on the podcast also talk about access and just the ability or fear around visiting doctors and not being able to afford it and such.
Yeah,
Yeah.
yeah, it's real.
And we've been talking a lot about what you do with your patients and in terms of how you treat them, but how do patients actually come to you? Like, do they get referred, or is it if they have chronic illness?
So the way that it works in the company that I work in, whenever we have a new doctor who's hired into the clinic, we advertise that here's a new doctor who's available. They're open to new patients. We put signs up in our specialty buildings. This particular group that I work in has urgent care where people can just go in and they won't see their own doctor. They just see whoever's working. The urgent care is open 7 days a week, 8 a.m. to 8 p.m. And so we put signs up at the urgent care that, like, if you're looking for a new doctor, here are the people that are available. We put signs up in the hospital. We put signs up at the specialist office. When people get an insurance, so they can go on their insurance website, like blueshield.com or whatever insurance that they have. And on their insurance is a list of all the open doctors. And you can filter through the website and through the zip code. And then what ends up happening is so much of it ends up being word of mouth. Those grandbabies that I was hearing about all these years, some of them are now my patients. And so family members and neighbors. So initially it's a lot of just make the word of mouth, like just, advertising that there's a new doctor who's open to seeing new patients. Doctors fill up very quickly. Primary care doctors fill up very quickly.
Okay. Okay. So to kind of look into the future and where medicine is going to be headed in the future, where do you see primary care heading in the next 10 to 20 years, and what kind of gives you hope about the future of primary care or worries you about it?
This is something that there has been a lot of talk about, especially in the world of artificial intelligence.
Mhm.
Will we even need doctors anymore? Will we even need certain types of doctors anymore? And I feel like, the reason that I went into it, that the reason of building these long-lasting relationships with people, that's not something that can be replaced with AI, at least not in a meaningful way. And so I think that there will always be a place for human doctors in primary care. I think that we will augment some of what we do with things like AI, but I think that ultimately people go to doctors to feel better. And it's not always medicines or treatments. Sometimes it's acknowledging and validating and just being present with someone. And so I think that there will always be a role for a physician in primary care. I think it's a necessary role. And so I'm hopeful. And I'm also excited about being able to augment so much of what I do with things like technology. So our system just got something called augmented response technology, ART, ART. And so the augmented response technology is those messages that I was complaining about earlier that patients feel like they can text their doctor. So those messages that come to me as the primary care physician, there's a little built-in response, an augmented response that, this is what your messages tend to sound like. And so it starts and ends a response to the patient. And then I kind of just fill in the stuff that would be pertinent specifically to that patient. And it kind of takes the mental load out of starting and ending a whole entire message. And so that's AI, where AI is starting this message to the patient and I edit what's pertinent and what's not pertinent. And so I can get through a lot more of those messages and still have it feel meaningful instead of this thing that I'm dreading. I think there's definitely hope for the future of primary care. I think there's definitely a lot of room to adapt technology and AI and things like that in medicine. And so I'm excited to see what the future of medicine will look like.
Awesome. And this is something that my co-host and I ask everyone we have on the podcast just to kind of close it off. But what advice would you give to anyone, either within college doing undergrad or high schoolers that want to go into the med field who are still considering it or unsure?
The biggest advice that I would give is to always come back to the why. Why am I going into medicine? And again, for me, it was to build these relationships with people. And so that reminder, even one or two of those interactions in a day, are so worthwhile. It's such a fascinating field, right? The human body is the same no matter where in the world you are. The fundamentals of the human body are the same. So you learn this art, you learn something that's so powerful. And then you get to apply that to different people and their interpretation of what their symptoms are like. And it's just such a beautiful relationship to have with the body. And so I think that just to remind yourself as to why am I going into this definitely makes more good days than not.
Hmm. Awesome. Thank you so much. Thank you so much, Dr. Ruben, for being on the podcast. You gave some amazing insights, and I'm sure people will learn a lot from listening to this.
Thank you for having me.
Of course. Thank
Have a
you.
good day.
You too. Thank you.
Bye.